Thank you for watching this short presentation on manual vacuum aspiration and pain management. My name is Dr. Asma Khalid, and I'm an expert in women's healthcare service provision and in quality of care. We at DKT WomanCare Global are passionate about high quality, rights-based care. Quality includes safety and effectiveness, but the experience of the patient is a critical component, especially as we seek to improve health-seeking behaviours. This talk will cover essential medical information, but also focus on the experience of the woman herself and how it affects pain management. Who could require an MVA? The need for an MVA can arise in any woman who is pregnant, anyone that we know, any woman that we might see on the street. The key point is not to prejudge her individual circumstances. This is relevant for pain relief because if the woman is made to feel uncomfortable or treated with a lack of dignity, pain and discomfort will be increased. Separately, there is good evidence that women who suffer from pregnancy loss also suffer from depression, anxiety, and even post-traumatic stress disorder, and we need to be mindful of the psychological states of our patients. The definition of unsafe abortion is relevant here because it discusses a minimum standard, and we need to be aware that this minimum standard includes provision of pain relief, so the skills and the appropriate environment need to be in place for a high quality MVA service. A special word about rights and counselling. Rights-based approach to service delivery has always been a priority from the WHO since its 1948 inception. It has gained more traction in healthcare and is a key component of the SDGs and also universal health coverage. In particular, it's been discussed in reproductive health, especially around contraception. Specifically for MVA, in our context today, we need to counsel the woman on what to expect and support her choices of method of uterine evacuation, and also her choices for pain relief by giving her the highest quality information, whilst also giving us an opportunity to assess her anxiety levels. As a useful tool developed by Engender Health for contraception provision, counselling, it's applicable to most healthcare settings, and the reference is on the slide. Non-pharmacological pain relief. The key points on here are pain relief or pain perception starts from the moment the woman makes contact with your service and until the moment she's discharged, and even after her discharge, where she thinks about the care that she's been given. Open communication techniques are critical and must be reinforced and need training given where required. A calm, welcoming, demedicalized environment is also crucial from the moment the woman makes contact with the service. Regarding distraction techniques, non-healthcare providers can be trained to provide these while the procedure is going on. And I have seen this happen and done very well in low resource settings as well. Pharmacological pain relief options. There are special considerations for pain relief that involve dilatation of the cervix, because the dilatation of the cervix, it causes pain. This is true for MVA, but it also includes other procedures such as IUD insertion, endometrial biopsy, and hysteroscopy. So these options are valid for those as well. After consultation with the patient and discussing with her what pain she may experience, you can make a plan with her about what might be the most helpful set of interventions. Routine administration of non-steroidals is pretty standard pre-procedure. Some women will also find the tenaculum placement very painful on the cervix, so local anaesthetic infiltration is indicated, or a spray if that is available. When the cervix does need dilatation, options include cervical infiltration, but particularly the key pain relief tool in our arsenal is paracervical block. That's injections not into the cervix itself, but into the paracervical area to infiltrate and disrupt pain fibers into the pelvis, as shown in the figure. The last option is sedation or general anaesthetic. And again, this is dependent on the patient and her own personal situation and needs. For example, this option may require to stay in hospital overnight, and that may not be acceptable to all women. The final point on here is that stopping the procedure is always an option, and thinking about how the procedure can be replanned so that the patient is pain-free. Now we can discuss the paracervical block in some more detail. As we just talked about, we inject local anaesthetic into the cervical site where the tenaculum is placed, usually at 12 o'clock. Some providers may prefer a 6 o'clock position, and that may be preferable where the uterus is retroverted or retroflexed. Don't rush to start the procedure or place the tenaculum once the local anaesthetic is in. But once it is placed, the cervix can be moved gently from side to side to expose the left hand and right hand side, cervico-vaginal junctions, and the uterosacral sacral ligaments, as shown in the diagrams. For injecting the local anaesthetic, the key points are about good injection technique, and these are the similar principles as for all deep injections. We first have to make sure that the injections are at the correct depth to hit those nerves that are going into the uterus. So the optimal depth is up to 3 centimeters, and that would be at 4 points at the 2, 10, 4, and 8 o'clock positions. Avoid injecting into vessels, and always note the maximum dose of local anaesthetic can be given during a paracervical block. If it's not working at that stage, then we need to consider more robust pain relief. Finally, wait to start the procedure. Pay attention to the patient and respond to her needs. As we know, pain relief does not stop as soon as the procedure ends. This is the importance of counselling. If the woman has been made to feel comfortable in a clinic environment, there's an increased chance that she'll be open about her pain relief requirements. But regardless of this, offer a range of pain relief options, such as non-steroidals or even opiates. If, of course, the pain is severe or persistent, as clinicians, we must consider if something else is going on and consider other diagnoses. This may be especially relevant where we suspect a woman has tried an unsafe abortion. A special word about cervical preparation. There is some debate as to whether the cervix should be prepared routinely to make dilatation easier. Pain relief options may reduce as the cervix is more readily opened, but there are disadvantages to the woman with the side effects of misoprostol and prostaglandins, diarrhea, vomiting, and shivering, and fever. It is not a one-size-fits-all intervention. It depends on the patient, her parity, her clinical state, and her level of anxiety. As you can see, the WHO do not routinely recommend cervical preparation, but in the UK, the Royal College of Obstetricians and Gynecologists does. The key point on here is don't delay the procedure if we can avoid it. If a woman needs to have an MVA, then we need to press ahead with that as soon as possible and not create further barriers to care. The final slide is a good practice point about MVA methods as it relates to pain. And we say that D&C is obsolete as a method. Even when used as a cavity check after an MVA, it is associated with more complications. Why do we use these barbaric methods when we have gentle techniques such as MVA? And from the WHO last year, D&C causes pain and suffering to women. Its use is incompatible with human rights. So in summary, pain relief for MVA consists of a series of interventions, and they're not all pharmacological interventions. And women require care for them as an individual. The basis for all pain relief is creating the highest quality patient-centered environment where women are psychologically comfortable and providers can respond to their needs. A range of options pharmacologically should be available, including non-steroidals pre-procedure. And we need to ensure that our providers have appropriate skills and equipment for administering paracervical block. And finally, we need to ensure that the woman's pain is appropriately assessed before she goes home and that she has enough pain relief to go home with, as her pain may continue after the procedure. Thank you for your time.